Good morning, everyone. This is the hepatic lecture, and we're going to start with the cirrhosis of the liver. As you can all tell that alcohol consumption has increased over the last few weeks among households, mostly because of the quarantine, and people don't know what to do with their time. So, with this lecture, hopefully, people will be deterred from drinking too much. So this is the location of the liver and all the veins that are important and the surrounding organs. As you can see, this is the portal vein, and this will come. This will be an important vein to consider while we go through the lecture. So cirrhosis is a chronic progressive disease of the liver. The regenerative process is disorganized, resulting in abnormal blood flow, blood vessel and bile duct relationships from fibrosis. And this is very insidious, and it takes quite a bit of time for the liver to degenerate to the point where it is not functioning like it's designed to be. Here are some of the statistics related to alcohol consumption and also chronic hepatitis C. And it is considered the fourth leading cause of death in people between 35 and 54 years of age. This could be the age group where most people drink a lot, even though it also happens in the younger population. But as you get older and as the years of consumption increases, so does the risk of the liver degenerating. As you can see, that's a healthy liver, and that looks like a marinated steak. So the time it takes for the liver to go from this to this is very significant. The etiology and pathophysiology, there are 5 types of cirrhosis. That is alcoholic, otherwise also known as Lennox. I'm not sure if that's the correct pronunciation. And then there's the post-necrotic cirrhosis. This is due to the different types of hepatitis. There's biliary cirrhosis, and then there's cardiac cirrhosis and NASH. NASH is the non-alcoholic steatohepatitis. This is largely like fatty liver. I'm sure you've seen this in the hospital too. So the alcoholic cirrhosis, otherwise known as absolute cirrhosis, from the absolute vodka, mostly associated with ETOH abuse, and then theoretically reversible fatty infiltration of the liver cells, and then widespread scar formation. If you remember the slide from previously comparing the two healthy liver and the cirrhosis liver. So that's the widespread scar formation, which makes the liver look like a marinated steak. And like I've mentioned before, during my lectures, I'll keep giving you points and pointers rather for possible test questions. And so if you pay attention, you will do just fine on the exam. Exam 5 coming up has a lot of my content, and this is the hepatic. We also have the GI content, and I believe end of life. And so just keep up with your recorded lectures, and you'll do just fine. But at the same time, make sure you review your textbooks just for comparison. Some of the data that's provided on here might be a little outdated, and so for exam purposes, we will not be using obscure numbers. Let's say the lab values, if there's a difference of a 0.3 or 0.4, that doesn't really make a difference unless it's a huge difference in the value. So then we also have the post-necrotic cirrhosis. This is a complication of toxic or viral hepatitis, like I mentioned, and it accounts for 20% of the cases of cirrhosis. So broad bands of scar tissue form within the liver, and then it regenerates the liver to a point where it doesn't get proper circulation, and then it leads to cirrhosis. When I say regenerate, it means it basically establishes new pathways that are not efficient for the liver to function, not regenerating in a good way. Let's see, we're gonna move on to the biliary cirrhosis. This is associated with chronic biliary obstruction and infection, and it accounts for 15% of all cases of cirrhosis. So there is normally 1 liter of bile production per day, and so if there's a blockage, this causes problems and backflows. And to fix this, sometimes they put in a shunt to drain the bile away from the liver. Then there is the cardiac cirrhosis coming from severe right-sided heart failure. So for the NASH, the non-alcoholic steatohepatitis occurs mainly non-alcoholic drinkers. It affects the middle age and overweight, but not all. The cause is mostly unknown. Okay, so here the lab value abnormalities with liver cirrhosis. So there will be a prolonged prothrombin and INR. There'll be a significant decrease in albumin, and then ALT will be elevated, AST will be elevated, and then elevated bilirubin. Normal is 0.2 to 1.2, and so if you see numbers that are way out there, then know that there's an abnormality. But you need to know that there'll be problem with clotting, and that's why there's a prolonged PT. And then the INR will also be prolonged, and decreased albumin, and elevated ALT, elevated AST, elevated bilirubin, and then ammonia. Ammonia is what causes most patients to have altered mental status, and so we do give lactulose to get rid of the ammonia. And note that I have stayed on this slide for a little bit longer, and so that's a clue for you to get familiar with this. These are some of the diagnostic studies that they use to diagnose liver disease or to intervene, like the EGD, they can go in and open up a duct or something like that. So the early manifestations of liver cirrhosis, it's like I mentioned, the onset is very insidious. Basically, patient might not have any symptoms, but then some of the early symptoms will be anorexia, dyspepsia, flatulence, nausea and vomiting, and then there's a significant change in bowel habits. And then there's also abdominal pain, fever, lassitude, basically patient having unexplained weakness or malaise, and then weight loss, enlarged liver or spleen upon physical exam. And then the later manifestations, the patient will have like spider angiomas, as seen here in this picture, and then palmar erythema and jaundice. Aldosterone and estrogen metabolized and inactivated by the liver. Breast enlargement in men, and then alteration in hair distribution. So basically they become, there's less and less hair present on the body, and mostly pubic and axillary and pectoral alopecia. And just note that with the breast enlargement noted in men, remember this slide, that's what I'm trying to say to you. Here's a picture of a patient with ascites and gynecomastia. Palmar erythema that I was talking about. This is because the liver is unable to process the estrogen. Hematologic disorders include decreased production of hepatic clotting factors, prolonged PT like I was mentioning. There's a deficiency of vitamin K, and then as a result anemia and thrombocytopenia with spleen engorgement. So anemia, leukopenia, and thrombocytopenia result of hyperplanism, engorged spleen. So the patient ends up being at risk for infection. These patients also develop peripheral neuropathy because of dietary deficiencies of thiamine, folic acid, and vitamin B12. For the most part, when these patients are hospitalized, we start them on these vitamins, and with the hope that it will boost their deficiencies or replenish the deficiencies. And then also patients will have dry, itchy skin, and so it's important that we start them on the vitamins. Jaundice is another late manifestation of cirrhosis, and this is as a result of insufficient conjugation of bilirubin by the liver cells, and then also bile salts deposit in the skin, eyes, and mucous membranes. And like I mentioned, patients develop itchy skin, and this is because of the bile salts that are deposited there. Okay, you can review this diagram. Portal hypertension, remember the portal vein from the initial photograph. So there's increased venous pressure in the portal circulation, leading to splenomegaly, esophageal varices, hemorrhoids, systemic hypertension, ascites, and peripheral edema. For the most part, these patients look like they're very malnourished, but they'll have a big abdominal gut, and because of the lack of nutrient absorption, they'll have skinny arms and definitely marked ascites like we talked about. They will have hemorrhoids as demonstrated on the underwear there. And then this is the caput medusa. So this is a portal hypertension is a late manifestation of liver failure. So they will have all the symptoms of liver failure and all this added to it. Here's an actual patient with a caput medusa. If you smell a patient with advanced liver disease, their breath is usually musty, sweetish odor, and it's mainly from accumulation of digested byproducts. So basically the body is not processing everything they eat. It is coming back as a bad thing. And then there is peripheral edema and ascites, intraperitoneal accumulation of watery fluid containing small amounts of protein, hypoalbuminemia. So basically, patient's albumin level will be low, and whenever we admit these patients, we give them albumin to help pull the fluid into the vasculature. And then increased levels of aldosterone and portal hypertension. Collaborative care for ascites and edema. Diet high in carbohydrates, low protein only during flare-up, really need more protein due to muscle wasting. Low sodium diet, 250 to 2 grams a day. This is mainly to prevent accumulation of fluids or retention of fluids. And then diuretics, spironolactone and Lasix, and paracentesis. 10% of patients may develop peritonitis after paracentesis. The normal fluid taken off is 1 to 2 liters, and then it recollects really quickly. The key thing I want you to take from this is that as a nurse, your role is to make sure that the patient empties the bladder before the procedure. The main reason being that if the bladder is full and they go in to do the paracentesis, they may accidentally nick the bladder. This is one of the other procedures that is done for patients. They put in a shunt that drains the fluid away. But the problem with this is that it might end up bringing in waste into the circulatory system. Oh, there it is. Returns more ammonia to the system, increased risk of hepatic encephalopathy. So hepatic encephalopathy is the elevated ammonia levels that lead to patients' altered mental status. And the only solution for that is lactulose, and have the patient have several bowel movements, and the dose is titrated depending on the mentation of the patient. I would just add to review again the lactulose dosing. Most of the time, we'd like patients to have at least five bowel movements a day, but then as the mentation improves, we target at least 3 bowel movements a day. So this is the explanation of hepatic encephalopathy. So basically the ammonia enters circulation without liver detoxification, and it gets into the blood-brain barrier. Main pathogenic toxin is ammonia, like I mentioned, and this is frequently a terminal complication. Impairs neural function, there's a flapping tremor, and then stupor, coma, lethargy, irritability, memory loss are some of the early signs. Whenever we have these patients, they normally confused and they're very mean to the staff. But once we get the lactulose on board, they start, their mentation improves, and they don't remember how they were acting prior to the event. So just remember, when you're dealing with patients in this condition, remember they don't know what they're doing or saying, so you have to be very patient with them. So the goal is to reduce ammonia formation. Protein is restricted. Sterilization of GI tract with antibiotics, like neomycin, or we also do Flagyl. So lactulose traps the ammonia in the gut, and they get it out through having bowel movements. And then levodopa with the shakiness. But at the same time, you need to monitor renal function because of the medications. So collaborative care for esophageal varices is to avoid alcohol, aspirin, and irritating foods. With the aspirin, I'll say include any NSAIDs, because that will increase the risk of bleeding. Patients can have slow bleeds, and that may lead to anemia. If acute bleeding occurs, stabilize patient and manage the airway. Vasopressin is administered, and beta blockers. So this can be managed with endoscopic sclerotherapy or ligation, balloon tamponade. I believe you will go through this, get familiarized with balloon tamponade in 4th semester. The other intervention will be surgical shunting procedures, like the portal cave or shunt, transjugular intrahepatic portosystemic shunt, otherwise known as TIPS. And then this tube, I can't pronounce the name. You can review this slide. So post-systemic shunts shunts blood away from varices to help prevent bleeding episodes. So summary manifestations of liver cirrhosis. Neurologic is hepatic encephalopathy, otherwise known as altered mental status. Peripheral neuropathy, asterixis. Integumentary is jaundice, spider angioma, palmar erythema, purpura, petechia, and caput medusa. Hematologic is anemia, thrombocytopenia, leukopenia, coagulation disorders, and splenomegaly. Metabolic, potassium deficiency, hyponatremia, and hypoalbuminemia. This is a very good review slide, guys, for your review, for exam review specifically. And then cardiovascular is fluid retention and peripheral edema and ascites. Reproductive, amenorrhea, testicular atrophy, gynecomastia in the male, and then impotence. GI, anorexia, dyspepsia, nausea, vomiting, change in bowel habits, dull abdominal pain, fetal hepaticus, esophageal and gastric varices, hematemesis, hemorrhoidal varices, and congestive gastritis. This will be a really good slide to review multiple times, okay? Oh, skipped one. So drug therapy, there is no specific drug therapy for cirrhosis. Drugs are used to treat symptoms and complications of advanced liver disease, and that's sodium. For sodium retention, we give the Lasix to get rid of the fluids, and then aldosterone production, you give them the aldactone. Ammonia retention, we give the lactulose, and then a bunch of B vitamins because of the deficiencies. So nursing management, your role specifically is make sure the patient gets tons of rest, measure abdominal girths and daily weight. I have not seen abdominal girths measured in these patients, at least not at UC Davis, but we do daily weights. Monitor the edema and ascites. Dyspnea is a problem because of the ascites, the stomach is pushing up against the diaphragm, and so patient has trouble breathing. Mentation of the tremors. Also monitor them for the alcohol withdrawal. Monitor labs and make sure to prevent bleeding. As far as labs go, we only take the initial ammonia levels, and we do not do a repeat because the assumption is that we will know if the levels are coming down by patient's mentation, specifically if they're getting a result from lactulose dosing. So which of the following findings are expected with liver cirrhosis? Sodium of 138, that's a normal finding unless it's outside the number. So according to, I go by UCD values because that's where I worked as a nurse, and so normal is considered 135 to 145, so this is within normal range. Bilirubin 2.0, that's elevated. Asterixis, that is you can find where it's expected with liver cirrhosis. Acetone breath, that's right, and the dyspnea, like we just talked on the previous slide. And looks like this is the last slide, but I have some notes that I wanted to review with you guys, just for the purpose of your soon exam. So these abdominal swelling with advanced liver cirrhosis, and then portal hypertension and decreased albumin that causes the fluid to shift into the peritoneal space. This is as a result of increased pressure in the portal venous system. And then some of the signs and symptoms of advanced cirrhosis is gynecomastia, which is the enlargement of the breasts in the male population. And this is as a result of changes in estrogen. We also get esophageal varices, altered mental status, coagulation disorders that I've mentioned, and ascites. So coagulation disorders, this is due to the impaired production of clotting factors, and then the ammonia level rises because the liver is unable to process the protein, leading to hepatic encephalopathy and behavior changes, and potassium is low. Like I mentioned before, the PT will be elevated and the albumin will be decreased. Patients that report a history of IV drug use should be screened for hepatitis C. And we are going to review the lecture on hepatitis and pancreatitis. And that brings us to the end of the liver cirrhosis lecture.